Hi, and welcome to the initial seminar for BMI of Texas. My name is Duperier, and I'm a surgeon, and I look forward to meeting you in person. But before we meet in person, I wanted to walk you through an introductory slideshow, an informational seminar, if you will, regarding what I hope is your upcoming weight loss surgery journey. All right, so welcome aboard. So for the next 35 or 40 minutes, hopefully I have your attention and you can take notes, and obviously you can watch this anytime that you want. But this will really give you a good primer and introduction of what's to come if you decide to pursue weight loss surgery. So this is just an information gathering session. Obviously no decisions need to be made today, and we'll get started. All right, so the outline of this talk is that I'm going to introduce our practice. I'll introduce you to me and my partner, Dr. Engelhardt, and we'll discuss some non-surgical options and educate you about what the surgical options are. And then we'll talk about life after weight loss surgery and some of the next steps if you decide that you want to pursue it. So who am I? Well, my name is Treve Duperier, and I've been in practice since 2002. And I've been either directing or co-directing a fellowship since 2008. And a fellowship is when you finish your training as a surgeon and then you go spend an extra year in creating a subspecialty. And so we have one or two surgeons that spend an entire year with us, and we teach them the intricacies of weight loss surgery and foregut surgery. And I did my fellowship at the Cleveland Clinic Foundation, which is in Cleveland, Ohio. And I would say that I am devoted to weight loss, foregut, as well as endocrine surgery. So I'm an endocrine surgeon on Tuesdays, but on Mondays and Wednesdays, I tend to be a foregut and weight loss surgeon. My partner, Dr. Engelhardt, he actually did his fellowship here in San Antonio at the BMI of Texas, and he was one of our first fellows. And I am proud to say that he's nationally recognized in the treatment of reflux, and he does some great things. And he's been in practice since 2012, and he is devoted to weight loss surgery, foregut surgery, and in particular reflux surgery. All right, so what makes our practice unique? You may find yourself essentially shopping around and looking at other practices, and you may decide, well, which practice do I go with? And so what I would say is what makes us unique is that both me and Dr. Engelhardt are fellowship trained. And believe it or not, a lot of surgeons that are specializing in things like weight loss surgery are not fellowship trained. And so that's a really big deal. At BMI of Texas, we host the only bariatric fellowship in South Texas. So surgeons, like I mentioned, apply, match, and then move to San Antonio, and they're taught by us for an entire year. And there's only one bariatric fellowship in all of South Texas, and that's with us. So, we educate people. The other thing that makes us unique is we use what's called in-office fluoroscopy, and that's a dynamic x-ray that's in our office. It actually is very informative, but it actually saves you time and money. It's a great convenience for you as a patient if you have a problem, and as well as helping modify your behavior. And it's really just a unique thing that I think makes us stand out. At BMI of Texas, we have performed thousands of operations, and we offer all forms of weight loss surgery, including the duodenal switch. So you're going to see in a few minutes when I talk about the different surgeries, there's the sleeve gastrectomy, there's a gastric bypass, and there's also the duodenal. And it's no secret I'm passionate about the duodenal switch, but most practices don't really offer this as an option because it's too complex. And so again, you should be asking yourself this when you're looking at other practices. If you're shopping this around, you should ask yourself, hey, are these surgeons fellowship trained? What surgeries are offered? Can they perform the duodenal switch? That will give you an idea of the complexity that those surgeons are capable of. Is the practice part of a center of excellence? Does the practice offer non-surgical weight loss, either before or after surgery, which is very important? And then also, what is the post-operative commitment to the practice you might be looking at? There are some practices that are very surgery heavy, but they don't focus on the post-operative commitment. And as a result, you're not going to see the long-term weight loss results that you would if you have a dedicated post-operative program. And is there a multifaceted approach to the post-operative care? And then always you want to say, hey, how many weight loss surgeries have you performed? All right, so let's talk about obesity. What is the impact of obesity? Well, obesity is a disease. Morbid obesity is when your weight creates medical problems or makes the medical problems that you have worse. And I'm sure it's no surprise to you that 2/3 of deaths in the United States can be attributed to problems that are created by obesity or with diabetes. So it's a big deal, right? And obesity is complicated. It's a disease. It's a multifactorial problem. It's created by a combination of medical issues, behavioral issues, social issues, genetics, as well as environmental issues. And I think it's really important that you know that being obese is not necessarily your fault. It's not your fault. And it's complicated. And you need to consider going to a practice that is dedicated to treating obesity and with all of the multifactorial problems that come along with it. Now, it's probably obvious that if you look at the problems that are created by being overweight, you see things like high blood pressure, sleep apnea, cancer, diabetes, joint problems, even infertility. It's amazing how many kids have been born as a result of having weight loss surgery. Because once you have weight loss surgery, it's much easier to have and much easier to carry a pregnancy. It's much easier to have a baby, and you create a healthier environment for the baby when you are pregnant. And plus, the hormones are a whole lot different when you're healthier, and it's easier to carry a pregnancy. So all of these problems, our goal is to get rid of these problems as you lose weight and consider having weight loss surgery. We can treat obesity two ways. We can treat it non-surgically and surgically. And at BMI, we try to approach this with clinical oversight and coordination, and we try to approach this in a multifaceted direction. We will do nutrition evaluations, we work on behavioral therapy. There may be certain drugs that are medicines that you're a candidate for, like I'm sure you've heard of things like Ozempic and phentermine. Those are examples of meds that can be used for weight loss. And then there's surgery. And then there's the post-operative care as well. But again, at BMI, we try to approach this in a more comprehensive fashion and not just focus on surgery. Let's start with what is non-surgical weight loss. Well, non-surgical weight loss means losing weight without the help of surgery. And it's offered to patients who need to lose weight in preparation for weight loss surgery, but it's also used as a way to augment weight loss after having weight loss surgery. So results and data demonstrate that when you use techniques of non-surgical weight loss in combination with surgery, it provides superior results than if you just do surgery alone. Okay? And again, that can include anti-obesity medications, behavioral modifications, working with the dietitian, doing self-monitoring of food intake, mindful eating, considering meal replacements, and of course, exercise. I'm sure everybody's heard of things like Ozempic and Mounjaro, and the truth is they're amazing medications. But oftentimes if you stop the medication, the weight comes back and the cardiovascular risk will come back also. And you don't hear about this much, but at least 15% of patients do not respond to medications like Ozempic or Mounjaro. If you're interested in what the results are, Ozempic provides about 17% change in your body weight, and Mounjaro is a little bit better. But it can come with some annoying side effects like nausea, vomiting, reflux, And as you lose weight, gallstones can be one of the side effects. I can tell you myself, I can speak for myself. I've tried the medications. I tried Ozempic and Mounjaro, and I thought they were terrific. But I personally had such an amazing amount of reflux. It was oftentimes debilitating. So again, medications aren't for everybody, despite what you might hear and see on TV, etc. And you cannot take the medications if you're of childbearing age. And currently, at the time I'm recording this seminar, these medications are very, very expensive unless you have a medical problem where your insurance might pay for it. I know of stories of people that pay $1,000 a month to get these medications, but not everybody can afford that. Your journey at the BMI of Texas is a non-surgical weight loss lifestyle modification. There's counseling, goal setting, and there's education not only before, but also after surgery. We might engage with medications, but we're going to also try and engage with behavioral therapy, teach you some self-monitoring techniques, and we're going to get you to start exercising and moving more. When you think about this journey at BMI of Texas, think of it like building a pyramid, and surgery would be at the top of the pyramid. And the building blocks at the bottom, the foundation of the pyramid that you're building, are the things that I just mentioned. Learning what mindful eating is about, learning how to use the app in food journaling, which I think is really hard. But if you make that commitment, you make that investment, these building blocks will serve you well, not only before surgery, but also you can apply them after surgery. Okay? And then after surgery, you can come back down and still go back on medications again. But if you put all these things together, you can have a terrific result. I would suggest that you work on the lifestyle. Don't think about this as a diet. Think of this as a lifestyle. And if you are dedicated and consistent with the lifestyle, the weight loss will happen naturally. But the more invested you are, the better the results will be. And you have to be ready for the change. You have to have had that inflection point where you're like, doggone it, I'm ready to make the change. And really, for a lot of you, the journey is starting right now as you're listening to this. And I hope it does. All right, we're going to switch gears now. We're going to talk about surgeries. Okay, we're going to talk about the top of that pyramid. There are several different types of surgeries. You may have heard of the adjustable gastric banding. There's a sleeve gastrectomy. There's a gastric bypass, and then there's the duodenal switch. The first is the gastric banding, and you can see in the slide where there is literally almost like a belt that goes around the very top of the stomach, and it's attached to some tubing and to a port, and the port actually sits right underneath your skin. It's similar to a metaport, if you know what that is. And the port is accessed, and fluid is put into the port, and the belt is made tighter and tighter and tighter over time. Now, we do not perform the band anymore because really there are too many complications, most of them minor, but there's just too many complications compared to the other operations. However, we're very happy to treat and care for band patients, and if you know someone who's had a band that is no longer seeing their doctor or their surgeon, we're happy to see those patients. In fact, that's the biggest reason why we have the fluoroscopy I mentioned earlier, because we use the fluoroscopy to access the port and to see what the band looks like, what the esophagus looks like, etc. Well, like I said, we do the in-office fluoroscopy. It improves the accuracy of the fills, it reduces the number of fills, and it just makes things a lot safer. Moving on to the sleeve gastrectomy. The sleeve gastrectomy is obviously very popular, and it's actually the most popular of the weight loss surgeries, and there's a couple reasons for that. And probably the biggest reason is that if you look at the diagram, you can understand it. You don't have to be a surgeon to understand that, oh, wait a minute, 80% of my stomach is now gone, and there's no rerouting of the intestines. So food comes down your esophagus and goes into that where it says gastric sleeve and out the pylorus, and there's no rerouting of the intestines at all. But this portion where the stomach has been excised that's the stretchable part of the stomach, and it's also the part of the stomach that is the main area where a hormone called ghrelin is produced. And so here we remove 80% of the stomach, and now you're left with a tubular stomach that doesn't really like to stretch. And so you get full very quickly, and as a result, you don't eat as much, and as a result, you lose weight. Now, the sleeve gastrectomy is obviously permanent, right? Because we remove the stomach, and off it goes to the pathologist. So it's irreversible. And these days, most of the time, we're doing it as a same-day surgery, meaning you have the surgery in the morning, you leave in the afternoon. And the goal is to have your stomach shaped like a banana. And it is the most common weight loss surgery performed in the world, and there's no absorption issues, okay? There's no rerouting of the intestines, so it's easy to understand. Now, it's actually the first half of the duodenal switch. So the sleeve gastrectomy was born from patients who could not complete the duodenal switch at the time of surgery. So for example, patients undergoing a duodenal switch, and maybe it was from anesthesia or for technical reasons, but surgeons couldn't finish the operation. They're like, oh, we're left with a sleeve gastrectomy, and let's see how patients do. And hey, this surgery works really well. Patients are happy. And so that's how the sleeve gastrectomy became the sleeve gastrectomy. So one of the powerful things about the sleeve gastrectomy is that it is convertible to a duodenal switch. So for example, if I see a patient and they're very high risk and we can do a sleeve gastrectomy, and then 6 months or 6 years down the road, we could convert the sleeve into a switch, if that makes sense. It can be done as a staged operation. Now, insurance companies don't always like to play nice in the sandbox when we have that conversation, but the truth is it can be staged. Now, what are the downsides of a sleeve gastrectomy? Well, 25 to 30% of patients can develop new onset of reflux. If you have reflux, we can make your reflux worse, and that stinks. But if you never had reflux before and you have a sleeve gastrectomy, you could develop reflux in 25 to 30% of cases. Now, if you develop reflux, you can take medication. And in most cases, there's no problem. You might have to take medication for the reflux even for the rest of your life. But as long as you're happy and you're not having any issues, as long as you take the medication, then onward and upward. However, there are instances where the reflux is severe enough that it warrants conversion actually into a gastric bypass because the reflux is so debilitating. Now, when we look at the risks of a sleeve gastrectomy, there's obviously a long staple line. And if you look at the results across the country, it's about 1 in 700 patients can develop a leak. And you know, that's an unfortunate situation where maybe the staples aren't holding, and that may require other surgeries or other interventions. Moving on to the gastric bypass. The gastric bypass, and I'll show you a picture of it here shortly, is made up of 2 parts. And it gives you restriction and what's called malabsorption. So it gives you a very small gastric pouch, and what little you eat doesn't get absorbed quite as well because of the rerouting that's done. And the stomach is bypassed, hence the name gastric bypass, right? It's a gastric detour. Now, people say, hey, what happens to the stomach that's left behind? Well, it sits there waiting for food that will never get there. And it's a wonderful operation in the right setting. So let me show you a video. Here you see how a gastric bypass is essentially set up. The stomach is cut across the top and you're left with a small portion of the stomach, and it goes into your small intestine, which has been brought up there. And then there's another connection further down. And you can see this is also called a Roux-en-Y, and it's because of the letter Y. It is shaped like the letter Y. And so when you eat, food goes in this direction, and then if you see the little green arrows there, the bile that's coming from your small intestine meets down at the bottom where it says CCF, and that's where digestion begins, which is further downstream. Okay, and again, the stomach is bypassed. Now, it's a very powerful operation, and There are neurohormonal changes that lower your drive for eating, your urge for eating. However, you need to know that it does come with some baggage. I wouldn't say that it's a complication, but the bypass does have some baggage. So for example, when you have a gastric bypass anatomy, you're forbidden to take things like aspirin, Aleve, or ibuprofen. Those medications are called NSAIDs. And it puts you at risk for having an internal hernia. You can develop ulcers. So again, just like you can't take the Aleve or ibuprofen, we don't want you taking steroids by mouth. And right now you may not need any of these things, but gosh, 10 or 15 years from now, and if you get sick and someone says, well, you got to take these steroids, that could be a problem for you with the gastric bypass. And it is not uncommon that at some point in your life, we might have to operate on you. And really, it's tantamount to just taking a look under the hood. All right, it's very minor surgery. And most patients are like, okay, yeah, well, so big deal. But again, that's my job right now, is to educate you. But it's not unusual to know that we have to take a look under the hood sometimes. And in my opinion, in our opinion, it's the best operation for patients that have certain medical problems like gastroparesis, Barrett's esophagitis, or severe reflux, or maybe a large paraesophageal hernia where you have a lot of stomach in your chest. The bypass is probably the best operation. The bypass is the best operation in the galaxy when it comes to the treatment of reflux. And if you have a condition like Barrett's, where it's a precancerous condition and we have to divert the acid and bile away from your esophagus to reduce the amount of acid and bile exposure, then the bypass is really your best option. Now, the bypass, you can have a leak from a bypass. It's very unusual. You can have bleeding. I mentioned the ulcers or an internal hernia. And sometimes you can have a stricture. And this is not really always a complication because everybody wants a little bit of stricture. That's where it gets a little narrow at the bottom of the bathtub. So, it's it can be a little tight getting through. And, a lot of patients want a stricture. But sometimes strictures have to be opened up a little bit because they're too narrow. And if you don't follow up, then you can have vitamin deficiencies, right? Because there's part of your stomach and small intestine that have been bypassed. Let's move on to the duodenal switch. Now, this may be a little bit overwhelming initially, but it's really quite a good diagram. And if you start on the left side, you'll see where there's an A and a B. And I'm going to take you through the technical aspects of the operation. We transect the small intestine between A and B, and then what we do is we bring C up to A. So now you have a sleeve gastrectomy plus an intestinal bypass. So in some ways it's similar to a gastric bypass, but in this case the pouch is the sleeve, okay? But it's like two operations in one. You have a sleeve gastrectomy where you have a very restrictive operation where you can't eat very much. And then with the switch, because we switch the ileum, we switch the duodenum to the ileum, that switch, now you can't absorb that small amount of food that you just ate. So it's a very, very powerful way to lose a lot of weight. It has the best results. You get restriction and malabsorption. Now remember, if you think of your intestines like a garden hose, right? Now we've just made the garden hose a bit smaller, right? So the goal is to have 0 to 3 bowel movements a day. Now, I'm the first to admit that for the first years of my practice, I didn't perform or offer this operation because I thought everyone was gonna, I'd be on the phone all day just talking about diarrhea. But it's turned out that that's just not the case. And again, 0 to 3 bowel movements is the goal. And the switch is a very powerful operation. It provides the most weight loss and it gives you the best chance of keeping the weight off long term. And I think it's superior to the gastric bypass if reflux is not an issue. Unfortunately, however, many insurances do not like to cover this surgery unless your BMI is greater than 50, which is super, super frustrating. Now, there are actually 2 types of duodenal switch. Don't need to spend a whole lot of time talking about it, but there's something called the single connection or a SADI, and then there's the double connection, which is the traditional switch. They're very similar, but sometimes we do one versus the other based on if you have to pay for this out of your own pocket or what the insurance is making us do. Now, make no mistake about it, the stakes of doing a duodenal switch are much higher. You have to be fully engaged as a patient, and you have to understand that even the vitamins are different with the duodenal switch than they are with the gastric bypass or a sleeve gastrectomy. And those specialized vitamins are called ADEC vitamins because you need extra A, vitamin D, vitamin E, and vitamin K. And then we call them ADECs. And you need those every day because of your bypassing of the small intestine that's normally responsible for doing the majority of that absorption. So you need to supplement yourself with these specialized vitamins. And those vitamins are purchased from our office. And the expectation is you're always going to purchase your vitamins from our office. You must be vigilant. You can't have this operation and then drop off the face of the earth. You need to be vigilant. You need to be compliant and expect that you're going to get your labs done once a year. You may ask, well, gosh, I've already had this surgery, or I've had a band, or hey, I had a gastric bypass and someone that says I have a problem. Yes, we do perform revision surgeries, but this forum right now is really not not really the right time because every patient is so different. There are too many variables, and it depends on your previous surgery. And in my opinion, the evaluation needs to be personalized to your problem, right? So that's something that we need to meet with you personally. Just like I was discussing with a patient today, they're going to have to require relearning what they thought they were doing correctly. All right? Maybe it's because we do things a little differently at BMI of Texas, or maybe it's because their anatomy, they can't practice what they're going to need to do after their revision surgery. There's lots of variables. The bottom line is it requires an individual in-person consultation to get started with that. Okay. So let's summarize. Let's compare the surgeries. And so I put the sleeve and the bypass and the duodenal switch here, and I put and I gave you different columns to compare them all. So for example, you hear about a dumping syndrome, right? Well, you don't get a dumping syndrome with the sleeve. You don't get it with the switch. You can see here, you get the most weight loss. A bypass will give you more weight loss than a sleeve, and a duodenal switch gives you more weight loss than a bypass. Okay, back to work. Our expectation is that everybody will go back to work within a week. And we often tell you to tell your employer, hey, I need 2 weeks off, but you need to plan on going back after 1 week. That way you go back early and everybody loves you. In terms of nights in the hospital, usually it's 1 to 2 nights in the hospital for a bypass or a switch. It can be 2 nights in the hospital with a sleeve, depending on your insurance and where you have your operation performed. And sometimes it's 0 nights. You can go home the same day with a sleeve. All right, so what are the risks of surgery? The risks of weight loss surgery are very, very safe. We're talking mortality now of less than 0.1%. Okay? That's the same risk as having your gallbladder out. Okay? The technique has been mastered by many people. There are high volume centers that do this surgery very safely, and it's a very, very safe surgery. What are the other risks? It's not uncommon to develop gallbladder stones. If you lose weight rapidly, you're at risk for developing gallstones. Bleeding is very rare from this surgery. And oh, by the way, as you invest yourself in the practice, you lose weight getting ready for surgery, you can mitigate some of that risk with some pre-operative weight loss. You can become more mobile, etc. Let's talk about the initial appointment. What happens? Well, it's really just an introduction, right? It's a two-way introduction. We want to meet you and we want you to meet us. It's not a high-pressure environment. We're just meeting each other, gathering information, assessing risk, seeing what's feasible, not feasible, and you just want to come in and see if it's something that is an option. And we're happy to give you our unfiltered opinion on what we think, what operation might be best. Okay? And that depends on the medical problems that you have. There's no pressure to make a decision whatsoever at that initial appointment, and we discuss the different options. And then we come up with a pre-op checklist. We might order an echo of your heart, an ultrasound of your gallbladder. I am really strict about getting people tested for sleep apnea. If I suspect you have sleep apnea, I'm going to want you to get a sleep study. And then we'll take the opportunity to meet your advocate or your navigator, and they'll be the ones that will shepherd you through the process of your insurance, etc., and in getting on to surgery and helping you make your appointments, like with the dietitian, etc. Now, people always talk about losing weight before the surgery. This is something we'll discuss in more detail at your last visit prior to surgery. And yes, we do put patients on a pre-op diet, and that's usually 10 to 14 days prior to surgery. It's designed to jumpstart your weight loss, right? We want to get things started for you. We want to shrink down your liver a little bit, but we also want to make you more mobile, right? If you lose some weight before the surgery and you find yourself getting around and being mobilized easier, it's easier for you to walk because you're going to be walking on the night of surgery. Hear what I'm saying? You're going to be walking on the night of surgery. That's not negotiable. So if you're able to lose a little weight before the surgery, it makes a big difference. What are the expectations before your future surgery? Well, obviously we want you losing weight before the surgery, and we want you working with our dietitian. If you have sleep apnea, we're going to work hard to get you a CPAP machine. You'll feel so much better. And if you're being treated for sleep apnea, it makes your surgery journey a lot safer, and you'll recover so much faster. You'll feel so much better even before the surgery. You have to discontinue things like nicotine or smoking or vaping. We will not operate on you if you are actively taking nicotine. Just can't, because it increases the risks of every possible thing that we could put on a consent form. All right, so you have to meet us there, right? We have to get you, we have to get you to stop smoking, vaping, etc. Before the surgery, we might have you doing some pharmacotherapy. Maybe there's medications you're a candidate for that we can get you started on in our non-surgical program to help you lose weight. And just understanding what the commitment is that's required for maximum success. Like I said earlier, if you can put all these things together, if you can lay those building blocks down, you'll have an outstanding result. What about after surgery? Well, you've probably heard that surgery is a tool, and you got to be accountable, right? The tool doesn't work by itself, right? I love the analogy of going to Home Depot and purchasing some tools. If they just sit in your garage and you don't use them, it doesn't really help you much, right? You have to learn how to use your anatomy. You have to learn how to use your tool. You have to learn how to use the surgery that you have, and you have to be accountable for that. The expectation is that you will take vitamins for your life no matter which operation you choose. And like I mentioned earlier, the stakes are much higher for a duodenal switch or a gastric bypass in taking your vitamins. That's really not up for debate. It's not negotiable. And we always expect you to purchase your vitamins from our nutrition store. We want you to support the practice, okay? Please, you don't need to go to other pharmacies to buy your supplements. Get them from us, and that way we know you're getting the proper vitamins that are bioengineered for your surgery. Okay, so now you've had your surgery. Now what? Well, the follow-up typically is about 2 weeks after the surgery. We take a picture and have you swallow in the in-fluoroscopy suite, in-office fluoroscopy suite. We have you take some barium, take a quick picture of what your new anatomy looks like. And then we have a recorded class at 6 weeks. But if you're having any issues or if there's things that need to be juggled, we usually see you around that 4 to 6 week window. And then at 8 weeks, we want you seeing the dietitian. And then at 3 months, you'll start seeing the providers, getting labs. And at 6 months, we also want you getting labs. And this is often a time where we might want to re-engage with those weight loss medications, right? So maybe during the process on this journey, maybe you were on a medication and we stopped it a week or two before the surgery. And now 6 months later, we put you back on it to augment the surgical weight loss that you've had. And then at the very minimum, we want to see you every 12 months at the minimum. But again, the more times you come into the office, the better you're going to do. All right? The more times that you come into the office, get your vitals taken, step on the scale, the more accountable you're going to be. That's part of one of those building blocks that I was mentioning. Please don't think of this like a diet. It is a lifestyle. And if you're wondering, how much protein you have to take, well, I'll give you a rough number. It's a rough estimate of 60 grams of protein. But it depends on a lot of things. It depends on how old you are, how tall you are, what your muscle mass is, what your, and there's a difference between chronologic age and biologic age. So don't get hung up on that, okay? We tend to ask you to limit your carbohydrates and work on lean proteins and healthy fats. We want you eating small meals. And if you're into protein shakes, we're going to focus on whey proteins. And we're going to try to teach you to separate your eating and your drinking. But more than anything, about mindful eating. We want to pay attention to cues. So for example, some sleeve patients will report, having hiccups. And I'm like, wait, patient, those hiccups are a cue that you got to slow down. You're overeating your sleeve. So we want to teach you these cues going forward. Hey, no surprise. Once you have weight loss surgery, you lose a lot of weight. We want you to be more mobile. And patients that exercise after surgery, they do better, especially when it's, when they incorporate resistance training. We want to preserve your muscle mass, okay? You might come into the office, like I saw a patient today, and they actually had not lost weight in the last month. But you know what? We looked at their bioimpedance measurements, and what was happening is they were losing fat and they were gaining muscle. Well, guess what? The net was 0. Right? So you got to take a step back and take everything into perspective. And let's face it, with exercise, all you need is a pair of sneakers. We just want you walking. That's the main thing right now. Just start walking, just doing something. Other things that are important. We are big proponents of the Bariatric Counseling Center. It's the only bariatric counseling center in the country, happens to be here in San Antonio. It's a terrific place where they do an emotional deep dive into your relationship with food. And patients do very well with this. The patients that I send there are all happy that they went. But it's intense, and it takes effort, and it takes time like everything else. But this is something that you might want to do not only before surgery, but after surgery. We also have a monthly support group, Facebook page, Instagram, online community, etc. And we offer counseling in our office, and it can be done virtually or in person. And we obviously want you seeing our dietitian. Again, I mentioned this earlier. The more one follows up, the better results you can expect. There's more accountability when you got to step on the scale once a month. And again, we might be adding some anti-obesity medications after the surgery to augment your results. All right. Changing subjects. In terms of getting pregnant, we do not want you getting pregnant for at least a year after your weight loss surgery. So we insist that you use 2 forms of birth control for a year, and you got to take this seriously because you become much more fertile after having weight loss surgery. There's lots of hormonal changes that make it easier to get pregnant, and getting pregnant is wonderful. And we just ask that you delay it for a year. It becomes too confusing to manage. And once you're a year out from surgery, no matter what operation you choose, it's just a lot easier for you to manage. Again, the decision for surgery, it's a rush slowly process. The decision does not need to be made today, does not need to be made at your initial appointment, and it's not the same for everybody. Just think about everything we talked about today in this seminar, and think about the things that you will learn and discuss at your initial appointment, and you sit back and you pray over it, you talk with your family, you let it marinate in your brain on your drive home. Just let it come to you. But do not think of this as a diet. We want you to think of this as a lifestyle, okay? You may say, well, gosh, is my insurance going to cover surgery? Well, that's a good question, and we'll help you navigate your insurance benefits because it's frustrating. A lot of people will have insurance, but they may not have benefits that cover weight loss surgery, right? It's similar to saying, well, I have insurance, but it doesn't cover dental or eye doctor appointments or a hair transplant, right? We'll help you navigate that. Our staff is highly trained and very experienced, and they will help you navigate this to figure out whether or not you do have benefits. And we'll discuss this with you at your initial appointment, okay? It's going to be very transparent. There's no baiting and switching here, okay? We're not trying to get you in and switch you to something else. It's all going to be very transparent, okay? Typically speaking, if you're paying surgery out of your own pocket, oftentimes the best value could be the sleeve because it's the least expensive, all right? And unless you need to treat a specific problem with a gastric bypass, like I said, a reflux or Barrett's, then typically patients that are paying for this out of their own pocket tend to have a sleeve gastrectomy. Okay, So we're about done with the seminar, right? What are the next steps? Well, you can make an appointment right now. The only prerequisite for your initial appointment seeing the surgeon is that we want you to watch this seminar. And you know what? You've done it. You're ready to go. Pick up that phone. You can also use the website to register and make appointments. And really, your surgery journey, it starts today, okay? And remember, this is a disease and this is not your fault. And you're going to be treated with compassion and respect, and I would be flattered to be your surgeon. Dr. Engelhardt would be flattered to be your surgeon. We'd be flattered to be your practice. It's complicated and multifactorial. It's a tool and it's not going to work by itself, so we've got to get you to engage actively. The best results are going to come from compliance, exercise, maybe some medications, surgery, etc. You've got to put it all together. And I'll leave you with this. A journey of 1,000 miles starts by taking the first step. All right? So think about that. I know this can be very intimidating and daunting, but you've already taken a first big step right now by listening to this seminar, and I look forward to meeting you in the office. Thank you very much.